Hi, and welcome back to Unraveled. I'm David Kaufman, and I'm here with my friend, colleague, and fellow YouTuber, podcaster, whatever the hell we are, Eileen Ruhoy.
Hello.
So we have a very, very special person, guest, doctor to join us today, Tania Dempsey. Um, I've known Tanya. How long have I known you now? 10 years? I was trying to figure out when we actually met.
Yeah,
I don't think you were not
yeah.
at the first mast cell meeting in California, were you?
No, I
Oh,
was.
that's
Yeah, I
when I
think
met you
that's
then.
I
Okay.
think that's when we met.
Yeah,
Yeah, yeah,
that's when we met.
exactly.
So that's 12, 10 years ago, I think.
10, about 10.
All
Yeah, yeah.
right. So it's been a tumultuous 10 years with a lot of work and a lot of learning. And I just think it's great that we have you on because you and I talk all the time about tick-borne infection, among other things. So
hmm
I'm excited about this
And I met you at the
podcast.
second
Me
conference,
too.
Yes, that's
Right,
right. It's in
Denver.
Broomfield in
Oh,
Colorado.
Broomfield, right?
right.
Yeah.
So
Yeah.
that was what, 20,
Oh,
the
what?
2018, 2018,
I think
Yes,
maybe
so. Yeah,
around there.
I
Bloomfield and
think so.
20,
Before
20.
COVID.
something like
So
that.
yeah,
It was
I
before
remember
COVID.
that.
Yes.
Yeah.
I had
can't
already heard
believe
your
that's
name and was already on that listserv and was reading everything. I'm always excited when I see your name on that listserv, unless
Oh,
I see David's name at this
yeah,
point,
I know. I know.
because I know
Yeah,
it's
because
either going to be a
usually
rant,
right. Me and my rants.
plain.
I love the rant. But usually, if David, whatever David's saying, is usually I'm saying the same
I
thing. Have you
agree.
Right.
noticed that?
I have
Like
Yes.
we kind
noticed
of like beat each other. It's so funny.
Yeah, it's very funny. And it happens
I,
over and
I've
over.
known, I'm not obviously not as close with you as David is, but I've known you for a bunch of years as well, since that
Yeah.
second Masterminds meeting in Broomfield, right?
Yeah,
So,
but we share patients, and we do
Oh
yes,
share
yeah,
we
we
have a
among
share
lot
a
of
lot of
patients
patients
too,
patients,
together.
right?
Yeah.
So
between all of us,
yeah, and I
So,
think that's important for our patient population because it takes a village, as they say. It
yeah.
requires
Yeah.
collaboration, right? Because I don't think one person can do it all. In fact, I know one person can't do it all because I've seen these complex patients come through, and they all have just a whole host of doctors, usually these large teams. And so it's really great to collaborate with those that I really trust, and
Right.
I think so highly of them, like I do with you, Tanya. And so I love sharing patients with you for that reason, just like I love sharing patients with David.
Same, same.
Yeah, and even patients that aren't shared. I mean, I love, frequently we'll reach out to Tanya or Tylene and ask questions. What do you think?
Right.
Any ideas,
Right.
et cetera, et cetera. So,
Yeah,
And I think we need to do that because we learn from each other
right,
constantly, right? I think
right,
that's
absolutely.
really,
right.
yeah,
And the learning is never over, right?
No.
never,
Great.
every day.
Yeah,
Well, and
every
again,
day.
that's what's so great about the listserv masterminds.
Right.
I mean, like today, I don't know if you guys have had a chance to look at today's, but there's this thread from Greg Plotnikoff as usual,
Nicole.
which is like, oh my God, where's he come up with this stuff? It's great.
I
What is
know,
the
I know.
topic? What's the topic today?
Uh, it was beta blockers and melatonin.
There's a
Yeah,
correlation.
Apparently, there's a
yeah,
correlation.
yes.
There
Oh,
you are.
Yeah, that's what he was
wow.
Right?
saying. And I just had him on my podcast, which will air probably in a few
Oh, I
weeks.
got to see that. I really
And
want to
we
see that.
talked about thiamine, vitamin B1, and its role in the immune system and mast cell. A really fascinating conversation of how
Wow.
he sort of got to this point. Yeah, yeah, we had some
He
really,
is
really
quite
Oh, I
interesting
look
brilliant
forward to
conversations.
that
and
one.
really, really
Yeah,
knows his stuff.
Yeah,
yeah,
Really great.
sure.
yeah,
So, Tanya, how'd you get here?
yeah.
Tell us in 25 words or less?
Okay. Oh gosh.
How did you
Okay.
go from being, I think you were initially a regular PCP like
Regular
me,
internist.
right?
Yep.
So how did you turn into a complex medicine maniac?
That's way of putting it.
Said with love.
Oh gosh, gosh. Okay, so I think it's helpful to give you a little background of just of who I am and my personality, because I think it's sort of, if I look back, I think it's inevitable that this is where I wound up. It's not by chance.
Right.
Because I really think that I always had this interest in um, the body as a whole, what the connections are between different parts of the body and different symptoms. I always had that sort of view of things, and I'll tell you some like funny little stories. When I started med school, I actually was bodybuilding, and right right when I entered med school. and I used to carry around. So I was really interested in fitness and diet, and I grew up that way. My grandmother was like an equivalent to a nurse practitioner in in Russia during the war. And I grew up with these stories of how she treated patients so compassionately, so holistically. I always had this sort of way of thinking about things, right? And then like to think about my childhood, I would remember my mother's favorite book growing up was The Vitamin Bible by Mandel. And if I had like a pimple, she'd be like, "Oh, let me look and look. Oh, you need zinc, or whatever." So I always had this like sort of a little more holistic view of things, that there was like connections in the body. Anyway, I entered med school and I carried around this book that was like the bodybuilding Bible of like nutrition. Okay, now you know how long we spent on nutrition at Johns Hopkins Medical School?
5 minutes.
At least at
Maybe,
that,
maybe,
right? I mean,
maybe 10. We'll give them the benefit of the doubt, right? And so like there was no concentration on that. And I became sort of the source for a lot of med students. They'd be like, "What does your book say about, what do you do for this or whatever?" And so what I started doing was really compartmentalizing my life a little bit, right? This was the life I lived, thinking about how to live a good life, my lifestyle, taking care of myself. Also, like really trying to understand again pieces. I always think about the puzzle pieces of a human, and then there was what I learned in med school and what I had to do for med school and what I needed to do to get through, right? And I really tried very hard to keep those two separate until they collided, because that was gonna be inevitable. And what would happen is, I entered. Well, actually, even before I enter, I'll tell you another funny story. I've told some of my patients this, and it's really kind of interesting. In residency, we would have a clinic. I did my residency at NYU Bellevue Hospital, and we had a clinic, that we would have to see patients, and many of these patients were part of the underserved population of the area, right? Some of them didn't speak English. We had Mandarin speakers, Spanish speakers, and you were lucky if you had a translator. But they would come in and they would complain of headache, joint pain, abdominal pain, all these different symptoms, right? And I would sit there and I would try to start to think, why, are they connected? Why does one person have all these complaints, right? The default of all my other colleagues and attendees was they're crazy, right?
mhm.
They must be just crazy. Why, how could they have so many symptoms, right? And I would sit there and maybe we had 15 or 20 minutes, maybe they give us a half hour. I don't even remember how long, but like an hour or two would go by, right? I would come out of the room, I would talk to the attending, and I would say, this is really complex, and I think this, that, and I would get in trouble. I can't tell you how much I was reprimanded in residency about how much time I was spending with patients, because I was trying to get to know them and trying to understand their life and how all these pieces, sort of fit together without knowing what I was doing really, right? But I just intuitively felt like that they all these things couldn't be happening in one body without there being some kind of connection, right? So, I remember this one conversation where my attending was sat down with me right as I was about to finish residency, and he said, "Yeah, I don't think you're gonna make it in medicine."
Oh my gosh.
You know how much I want to go back to him right now and tell him, not only am I making it, but I'm helping a lot of people. So,
Yeah,
Right.
exactly. You should
And
write him a
he's
letter.
probably miserable or has
Yeah.
already quit
And probably,
because the
I mean,
system
I'm
is,
sure that,
you know,
I mean, you're
yeah,
famous, so I'm sure he knows that you're doing great, that you're helping a lot of people.
I don't know. I don't know. But he just said, you're not going to make it in medicine, because unless you can concentrate on one symptom at a time, it's just not going to work.
yeah,
You're gonna drown,
yeah. That's the way we were all trained. I mean, that is the reason that
right?
people like the three of us are overwhelmed with patients,
Yeah.
because most of the system just doesn't know what to do. They've all been trained in that silo thinking.
Yeah. Yeah.
It's crazy when you think
So,
about the
yeah.
integrated systems of the body, it starts to make sense why there are so many symptoms when things go awry. So you cannot focus on just one symptom because you'll never really see what's going on.
Right.
Right. Like how could I take care of their headache when they're also having abdominal pain and they're
Right.
also having, let's say, all these other symptoms? I mean, would never get anywhere, right? They would never get better, right?
Right.
That's what I knew. And so that sort of my thinking, sort of continued into, private practice. And the same thing happened in private practice. My boss sits down with me, it's not going to work. You can't spend an hour when you have a 10-minute slot for these patients. And, at some point I just said, well, I don't really care. I really care about the patients. And I, just, started, continued to listen to them, continued to try. But I really felt like I was missing something. I really just didn't feel like I knew how to put the pieces together, but I knew that there was some connection. And I remember meeting another doctor locally who had an integrative gynecology practice actually, and
Wow.
he asked me what kind of it was some kind of like meeting of doctors in the area. I don't even remember, some kind of like program. And he said, "Oh, what kind of practice do you have?" And I said, "Well, I do internal medicine, but what I really love doing," and I started explaining to him what I was doing. I didn't know it had a name. I didn't know it was like a specific thing. He said, "Oh, so you do integrative medicine?" And I was like, "I don't know. I don't even know what that
If you
is."
say so.
Yeah.
And he's like, I'm sorry, I mean, you're going to say something.
I was going to say that I used to comment on how people would refer to me as an integrative neurologist, and I used to think, why? Like, why am I thought of that way? And I realized it was because I sort of see things more holistically, that I was just given that label. And I know I did an integrative medicine fellowship, and I used to think that was the reason why, but then I realized it was because of how I practiced, that that's how people referred to me. But anyway, so go ahead. Sorry, didn't mean to interrupt.
Yeah, no,
Well,
no, but it's
I
just
gotta add one thing. The irony
okay. Okay.
here, and I'm sure I've said this before, is that this is internal medicine used to be integrative medicine. That was the whole thing about internal medicine.
Exactly.
It was the intellectual, cognitively intense aspect of medicine,
Right.
and everybody sort of thought of internal medicine as the detectives and everything. And that was the original training concept. And it very rapidly got lost the minute managed care hit the streets. So,
Yep. Absolutely. Managed care actually destroyed medicine.
right, right.
Yeah.
Anyhow, go ahead,
Yeah.
Tanya. I'm sorry.
Yeah. Yeah. So anyway, so then, now I'm thinking, I started labeling myself like, okay, I guess I'm integrative. I started going to conferences. I started meeting other people. I started getting more tools to try to manage these patients. But I still far from where I am now. I eventually decided to start my own practice, and the goal of that practice was to provide primary care to patients in a setting where I had time to take care of them. I didn't take insurance, so I had the ability to really concentrate on them, their families, et cetera. And I started out that way. But the thing is, once you have time on your own to really talk to patients, right? Inevitably, you start to like, at least if you have my personality and your personalities, right? I just started reading and I started reading and I started thinking, I started putting things together. And eventually I connected with, I actually spoke at a conference on, I really started getting interested in like methylation disorders at
Oh,
some point. Like that was like a rabbit hole that I like went down at some point, right? So I gave this talk on methylation, and at the same conference, Richard Horowitz gave a talk on Lyme disease. And I always tell the story. It's kind of funny. My mother came with me to this conference, and and like she loves seeing me talk, but up until then, for the couple of years leading up to then, he was suffering from migraines, really bad migraines, and a number of other symptoms, severe fatigue, brain fog, and a bunch of other things. And I was still like working in that conventional model. I sent her to the neurologist to put her on migraine meds, still didn't help. And then we did this, we did that. And she was well past menopause, but she had horrible night sweats and she had palpitations and she had all this stuff, right? And I just didn't know what to do with her, right? But anyway, we're sitting at this conference and Rich Horowitz is talking about Lyme disease and he's going through the symptoms. He's talking about Lyme, he's talking about babesia. And my mother the entire time is like looking at me and going, "That- I have that, I have that, I have that," like
Check,
the
check, check,
typical.
check.
And I'm like looking at her and I'm like,
oh
oh
my
my
God.
God. It was
It's a
really
great
like,
Was your
story.
mother your
it was
first Lyme
crazy.
patient?
Yeah. Yes.
Incredible story.
Yes. Unfortunately. So then I went up to him afterwards and just started talking. I was telling him about my practice, and he said, "Oh, where's your practice?" And I said in Westchester County. At the time, I was in Armonk, and he said, "Oh, you must see a lot of Lyme." And I said, "No, I think I have maybe one patient." And he said, "No, you don't." And I said, "No, I think I don't either." Right. So that was like Sunday
Yeah.
afternoon. On Monday, I started seeing the patients, right? So I thinking about my mother, of course. And then I started seeing the patients. And now I have another lens, right? So then I start seeing them through a different lens and like, could this be that? Could be that. Oh my God. And then it was just like a flood,
Right. And it explodes.
explodes. And then that inevitably kind of like leads down this path of immune dysfunction.
Yeah.
And then it was like that one patient where I couldn't figure out, she was having all this shortness of breath um, uh, and a lot of mast cell symptoms, and I didn't couldn't figure her out. And at some point, I found mast cell activation syndrome online. I don't even remember what I was reading. I was probably on like PubMed or something. I don't know. I found something called mast cell activation syndrome, and I went, back to her and I was like, look, I don't think you have Lyme. I don't think you have it, but everything's negative, but maybe you have this syndrome. And then she had a family member who was connected with some researcher at the NIH who then said, "Oh, you got to talk to Larry Afrin." Right. And then that was like, then it's like all history after that. Right.
Right.
So
Exactly.
I get on the phone with Larry. Right. First off, I can't even believe he wants to talk to me. Right. I think you probably have
I
had a
had the
similar
exact same
situation.
experience. Go ahead.
Right. I call the office, right? They
Never
schedule
spoken
me to
to me
talk.
on the phone.
No. And so it was maybe like a 2 or 3 hour conversation,
I'm
right?
not surprised.
He just, it was like a brain dump. But I got off the phone and I was like, oh, I think this is what I'm seeing, you
Yeah.
know? And then once you start doing that, then it's again like you just can't unsee it.
Yeah.
And then you just like the practice. So that's a very long story, but that's kind of
Right.
where how
No, it's a
I've
good
gotten to
story
this
though,
point.
and definitely I think parallels a lot of our experiences about how we sort of arrived at where we are today, for sure. So I think that's a good story in terms of
Thank
just
you.
understanding more of like how you came to be who you are. So then you recognize mast cell activation syndrome and then what? Then like is it, I always like think about is everything a nail because we have a hammer now, that right? And that's, but it's
Oh,
also
great
like once you
point.
see it, you can't unsee it. So
Right.
it's like yin and yang. Every time I get a new patient, I'm very cognizant of trying not to make everything fit into the same box because
Yeah.
David and I often complain about how medicine is too siloed. And so I
Right.
work very hard. I know we both do, and we all do, I'm sure, work very hard not to just create new silos, right?
Right.
And I think
Exactly.
that that's really important. So it's not like everyone who walks through the door, oh, you definitely have mast cell activation syndrome. And I don't do a lot of tick-borne illness just because I don't feel that's my area of expertise. But, I wonder if those who do, like the two of you, do that as well to some extent.
Yeah. I mean, I, I agree that we are at risk for creating our own silos, and
Yeah.
we need to be vigilant about that. Um, I don't actually look for tick-borne infection. I don't think of it for every patient at all. But I do think of it if the history creates a great enough risk that I have to consider it. I mean, part of it, Tanya may laugh when I say this, part of it is that I'll do anything I can to avoid tick-borne infection because it is a rabbit hole of rabbit holes. It's torture. I
I do
hate
agree.
treating it. I hate it. And I tell
I
the
do
patients
agree.
that,
Yeah.
because we just don't know enough. And
Yeah.
even now,
Yeah.
20, I first kind of got into tick-borne infection with Ken Liebner, who's Richard Horowitz's corollary, so to
Oh,
speak,
yeah. Yeah.
right?
Yeah. Oh, I
Ken and
didn't
I
know
used to
that.
talk in New York, and he would send me his patients for IV treatments in New York. And I got deep down into the rabbit hole. And that's 30 years ago. And I'm still have that reaction of, oh, I don't want to take care of this problem because we just don't have the data,
Yeah.
you
Right.
know?
Yeah. Yeah,
But it's there. We can't avoid
100%.
it.
But there
And
are there is a consensus of treatment plans, right, for Lyme and Bartonella and babesiosis.
sort of. I think I'll let Tanya expand on that, but I would say
Mm,
there's a consensus based on zero clinical trial randomized trial data. There's never been, unless you know something,
yeah.
Tanya, I don't, there's never been an RCT, a placebo-controlled trial, looking at which treatments are better, which drugs are better, which is a real problem,
No.
you know?
Yeah, I mean, there are studies in vitro. There are, Johns Hopkins, they did a bunch of research, but again, they're looking at the bugs in isolation, not in the human,
Right, right.
and looking at what drugs, herbs, et cetera, work. I know Rich Horowitz is trying to get a randomized controlled trial for the Dapsone protocol. But the reality is that a lot of us use um, what we feel comfortable with and what we have found to be helpful, but we don't have a trial that
Right,
shows that
right.
that's
And
necessarily
and it's
helpful in everyone.
again, it's why I'll call up Tanya and say, "Well, what do you think I should do? I tried these and didn't get anywhere." Or
Yeah.
what are you doing after you go for Clarithrol and rifampin? What's your next,
Right.
Right.
uh, you know, a couple of antibiotics? And how, I mean, we just don't know. We don't know what the right drugs are, the right combinations are, how long to treat, and how to even prove whether the treatment's been completely effective,
Successful.
you
Yeah.
know?
Yeah.
Um, and to further complicate things, and this is something I'd love to focus on a little bit now, to further complicate things, one of the things I have come to realize, and I know Tanya has as well, is these infections. Let me back up a little. So we were taught, and I thought I knew and understood, that tick-borne infections were like other acute bacterial or parasitic infections. You got
Right.
infected, you either got sick or you didn't. Got treated, and you got better, and end of story.
Yep.
I've now come to see, thanks to COVID, basically, before COVID, not everything I'm about to say didn't exist in my brain before COVID, that these infections are absolutely reactivation infections. They are exactly like Epstein-Barr virus or HHV6. They reactivate, so you can get your infection at 12 years old when you're playing in the woods in Armonk, and then you never got sick. 30 years later, you get COVID. Bam, you also
Right.
have reactivated Borrelia or Bartonella or Babesia. And I'm still boggled by that, but
I know.
I just keep seeing it, and I think you feel the same way, Tanya. That's been your
Yeah.
experience as well, right?
Yeah, 100%. And I think the way I think about it, or started to think about it, I think I started thinking about it before COVID, but certainly the after COVID, it's been, sort of solidified. But, I think about it this way, yes, we're taught that sort of from an infectious disease perspective, that, you have an infection. And I love to use this example with patients. I'll use the example of strep throat, because I think it's actually a really great example because it's simple. People think it's simple, right? So, somebody gets strep throat, um, you give them antibiotics, 10 days of antibiotics. They get better most of the time. And but then the kid gets strep throat again a few weeks later, a month later, 2 months later, whatever, right? And the pediatrician says, "Oh yeah, strep's going around. Yeah, you probably got it again." They didn't get it again. That strep throat came from them, right? Because the strep has accumulated in the tonsils and has been dormant. And I think about it this way, during the strep infection, there are like a million strep organisms living in the throat. And you take amoxicillin and maybe you knock it down to 100. At 100, you don't have a sore throat, you don't feel bad. And they're just sort of living there. Maybe they go dormant. And then something happens, you get run down, they don't get enough sleep, they eat too much sugar, whatever the kid does, right? And then guess what? That 100 turns into a million, and now they have strep throat again.
So that,
And
that
so,
go ahead, go
go
ahead. I'm
ahead.
sorry.
No, no, no. So I've been thinking about this for like a long time because
Right.
I've seen patients like as an internist, even doing like adolescent medicine. We saw this all the time, and I'd be like, I don't understand, why does this kid keep getting strep throat? Like, and everybody else in the class doesn't. I mean, it's not that contagious, actually. I mean, it's contagious, but it's really has to do with the patient's immune system, has to do with their tonsils, has to do with their lymph system. I mean, there's so many variables. So I sort of think about it that way. And then I said, well, if that's what's happening with strep, then presumably that's also what's happening with Lyme, the
Right.
BC, Bartonella, and all these other infections. I think that, I mean, there are other variables that affect whether the patient gets sick or not. Okay. I think, right, there's immune dysfunction that maybe existed before the infection. There's probably some genetics. I think there's trauma. I think there's all this stuff that sort of predisposes some people to being sick. But I think the reality is that these bugs have a way of evading the immune system, going dormant, and then waiting for the opportunity to come out at the opportune time. So uh, post COVID, that's what I think we're seeing.
Right. Yeah, I mean, I think your example of strep is very, very significant
Yeah.
and correct
And
because
it's
it
one that everyone can
emphasizes,
understand.
yeah, and it
Mm.
emphasizes this role of the immune system,
Mhm.
Um, and you can flip it and say, well, when you got when the person got their tick attachment and Borrelia and had no symptoms, that's because maybe the burden of infection wasn't that great and the immune system was able to take over and and suppress it. All right. And it stayed suppressed or latent for however many years until something else, disturbed their immune function and immune competence. And it's the same with strep. It's the same with tick-borne. It's the same with EBV. It's the same with HSV1. Um, it's kind of staring us in the face, but somehow mainstream medicine does not recognize that. It's very
Right.
strange to
Oh,
me.
Yeah,
They
it's very
recognize it for
controversial.
shingles, for zoster,
Hmm.
but not for this. And it's the same model.
right.
Yeah, chronic
No,
infection is so controversial for sure.
Yeah. Yeah.
but
It's
but to me, it's just so commonsensical.
right.
Like it's not rocket science. We have other models of viruses and
Right.
infections that already do that. So why couldn't these other things do the same?
Right.
I
And
think
do we
another,
ever,
I'm
yeah.
sorry, go ahead, Eileen.
No, I was
Yeah.
gonna say, do we have any understanding in terms of what is the difference, like pathophysiologically, between an acute infection and a chronic infection, other than the obvious, acute and chronic? But what is the change of the physiology that allows something to become so chronic?
Well,
Good question.
I think
I don't know if
I
we,
think the chronic piece, I want to be careful in the use of the word chronic because
Yeah.
um, if if we were referring to the person who gets infected without symptoms and therefore no treatment, um, you can call that chronic, but they have nothing wrong. I think their immune system has just taken care of that infection in a suppressive sense. In other words, you wouldn't say when you got EBV at 4 years old, you now have chronic EBV, right? We would talk about
Right.
EBV acquired as an infection. The immune system locks that virus up in jail in the B cells, and down the road something happens. They have surgery, they have trauma, they have COVID, whatever it is, and the immune competence declines, and the bug says, "Oh, cool, I can break out of jail," and it reactivates. Just like with zoster, um, you get chickenpox as a 3-year-old, and when you're 70 years old, your immune system declines, or you have an infection or some other trauma, and you have shingles.
so you're saying
So
it's the reactivation so for example, in neurology, there are studies that show that EBV, as an example, is is associated with Alzheimer's, with multiple sclerosis. So are you saying that it's a reactivation of those dormant viruses
yes,
that
Yeah.
cause that and not just the chronicity of its presence in
right.
the body that's make see, because I was always wondering, like, just its presence, is there an insidious, maybe, so maybe decades in the making, change of physiology that would otherwise not take place that results in some neurodegenerative disorder at a later stage in life?
So you're asking, does the bug change over
Oh.
time? Is that what you mean?
Maybe. I don't know.
Or
I don't think,
well,
I think it's the immune
well,
system.
I don't know if I'm asking
well,
specifically about the bug itself. I'm just asking about the presence of a
what
bug.
is happening?
Right, it's like a foreign substance, right? So
Yeah.
else you got an implant and there are changes
Yeah.
that happen, right? Those kinds of things. So you have an organism that's foreign and that you are infected or exposed to at 3 years of age. And then over decades of life, are there changes that take place? And I don't think we really know the answer, but because you guys work so much with infection, I'm wondering if you have any thoughts on this. Like, are there changes that just take place physiologically because of the presence of that organism that results in some well-known, often, a consensus, oh yeah, MS is a disease,
Yeah.
Alzheimer's is a
I,
disease.
I-
So yeah, yeah, can
yeah,
I,
go ahead.
Oh,
yeah, I
yeah.
think, so I think they're actually two different scenarios. What Dave is talking about is where the infection is totally dormant
Mhm.
for a long time, right? And so we have patients who really had no real significant symptomatology or anything for many, many years. They get COVID, right? So presumably they think they're healthy, then they get COVID. Now we're dealing with this. Now we see Bartonella and the BC and all that. In those cases, I do think it was totally dormant, not affecting their body or their immune system
Mhm.
until it reactivated.
Okay.
But I do think there is a subset of people who have, and maybe this is where the term chronic maybe serves better. It's they actually have chronic infection, not there's no dormancy. It is a smoldering infection where over time they have more and more symptoms that their immune system is trying to deal with, but they can't. The infections themselves, Bartonella, um, causes small vessel disease. So over time, the Bartonella, right, is like simmering away, causing this inflammatory reaction. Next thing you know, these patients are having strokes or they're having these other
Mhm.
manifestations of small vessel disease, right? That's not because the Bartonella was dormant and then reactivated. That's because
Right.
that Bartonella was persisting and continuing to damage the body and the immune system's inability to knock it down. So I do think that they're
Yeah.
actually two different
Yeah. I mean, I
scenarios.
think
Right.
what
No, that
I
that makes
agree with
sense.
what you're describing. I just wish we had more proof.
Right.
And what I mean, we all have our fantasy perfect trials. We need a
Yeah,
prospective trial, which
yeah,
basically you take 1,000 people who are supposedly healthy, and you run their tick-borne disease testing, whatever testing you
yeah.
choose, whatever lab, and then you follow them over time to see in those that are positive, even though they didn't know they'd be positive, do they develop progressive illness the way you're saying?
And
I
I have
agree
a
with you, but I'd
patient.
love to see that trial.
Okay, I would definitely want to see the trial, but I will tell you a really interesting story. I have a family that I take care of. The three children have been dealing with Lyme disease for a long time, and they're now in their 20s, and they still have little blips of it. But at the time I started treating them, maybe like 10 years ago, they had a lot of sequelae from the infections. The mother was also positive, but she was less symptomatic, and so she was really more concerned about the kids. And at one point, when things seem to be, quiet with the family, they're generally doing okay. The father comes in and says, I feel great. I run 5 miles every day. I do all this stuff. But it occurred to me that, I probably should find out if I have infection. My whole family has it. And maybe there's something I should be doing preventatively or whatever, right? So not only does he have infection, I mean, his results were worse than his kids or his wife. I mean, off the chart antibodies, off the chart fish, everything positive. I mean, everything is positive. And so, we're faced with this scenario where I'm like, well, he
Hmm.
doesn't have symptoms. He has infection. Now, what do I do? He says, look, I want to do something because I really I'm worried about, we don't know what could happen, right? I said, okay, so let's do, a short course of antibiotics. Let's do some herbs. And then, let's just see, right? So he does antibiotics, he does herbs. I don't know, maybe over the course of 6 months, but he feels fine. He feels the same before and after because he's been feeling fine. And then 2 years goes by, and he comes in, and now he's not feeling that great. So now he's a little more fatigued. He has some other symptoms, right? Now he has Hashimoto's thyroiditis, okay, which he didn't have before. So now he has a thyroid condition, right? So now I'm like, oh, I bet you the bugs, right? So let's go look at the bugs again. Bugs are, of course, positive. And so I said, well, I think the bugs are driving the immune response. So now we need maybe a little bit more aggressive, whatever that means, right? Still not super aggressive. He doesn't want to take a lot of stuff, but we do some stuff. Maybe his antibodies do come down. Feels a little better. And then again, like time goes by. Now it's another few years, and he goes into atrial fibrillation,
Wow.
right? And he calls, and he's in the medical profession, he and his wife, so they know enough that he calls and on vacation he's like, I'm in atrial fibrillation. Is it my babesia? And I'm like, probably, but let's get your atrial fibrillation. Like, just get on something, figure this out. Come in, let's get tested. And when so he's of course positive for everything. When we started treating, and actually what he really wanted to be treated, we did a little antibiotics to just quiet things down, and then we started doing this SOT therapy
Hmm.
that I do, which we could talk more about, but it's
Oh, yeah.
supportive oligonucleotide technique.
I want to know more about that SOT because a lot of my patients are getting that, but go ahead.
Yeah, yeah, I'd love to talk about it. But we first like cooled him down with some antibiotics, and we started SOTs, and we did a few rounds of it. And now it's been, I think it's at least 2 years since he's had an AFib episode, and he feels that it's very clear to him when he would flare, his AFib would flare. Like he could start to see at one point the correlation, and now things are quiet. His thyroid looks okay, his AFib looks okay. The minute he starts to feel a little something, right, he comes in, we start, thinking about, do you need another SOT or whatever? So the point being is that this is the way I look at his case. I think the infection was smoldering over time, but he had a pretty good immune system for a long time, better than his kids or his wife, until he couldn't take it anymore.
Well, and don't
Okay.
forget, he also got older.
And for sure. Oh
And
yeah,
that, no, that does
for sure.
cause an immune
Yeah.
competence decline.
Yeah, 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 for sure. But he's not
But
that old. I mean, he's still only in his
yeah.
50s. So it's not like,
Starts.
but sorry, don't talk about aging. Okay. Um, we'll get there. But the point being is that like I think that I can't prove any of this, right? But when I see this sort of these new problems develop that are usually slower to develop, like a patient who, maybe has been, not feeling great, it's been a long time, and all of a sudden gets MS. I think it's the same thing. I don't think it's
Mhm.
a reactivation, is my point. I think it's the
Right.
persistence
Yeah.
of the
But
infections.
just the
I mean,
chronic provocation of the immune system.
right. It's a great case. I mean, it's a
Example.
great
Example.
example of the huge knowledge you can get from an N of one kind of case, right?
Yeah, that's how
Because
you learn.
that story you just described really encapsulates everything we're trying to say here, which is you can get the infection without any acute symptoms. It can smolder along with doing nothing, and then it can cause trouble. And then a physician like you comes along and treats it, but doesn't cure it.
Right.
It's,
Right.
it brings up this
Right.
whole other thing, which we'll get to in a minute about tick-borne infections and curativeness,
Sure. Yep.
cure of the infection. Um, and then the secondary sequela from those infections, and that is
Right.
exactly what you described. That's what I keep seeing in our post-COVID, long COVID patients. Um, and I would add that in those long COVID patients where I diagnose reactivated, what I call reactivated tick-borne infection, I'm very careful in explaining to the patient that I'm not saying your symptoms are just from that reactivation.
Right.
In fact, I'm not even sure that any of the symptoms are from that infection, but
Right.
I do know for sure that infection is not a good thing and it's adding to the burden and we need to treat it. And that adds to the whole confusion, the whole rabbit holeness of this problem, because they don't have the typical symptoms that you think of. They don't necessarily have fevers or joint pains or whatever. They have long COVID with POTS and mast cell activation and SIBO and leaky gut, but
Mhm.
somewhere in that mix is tick-borne infection that's reactivated along with EBV reactivated that just causes a mess.
Yeah.
So anyhow, it's a great story.
Yeah.
I
Yeah.
hope
I
he's doing
completely
better.
agree. I'm finding,
Yeah, he is. Yeah.
yeah, in the post-COVID world, I mean, at least clinically, like neurologically, what I see in these patients is just, I refer to it as autonomic catastrophe, like,
Right.
which sounds like Chicken Little a little bit, but it really,
Yeah.
that's what it's like. It's autonomic despair. So it's scary. It's really scary because they're just suffering so greatly. And I think that the root cause of it is really about obviously the COVID infection, but what the COVID infection had reactivated or had just built upon more of this chronicity that we're sort of describing. I think it's just sort of creating this cauldron of, of an explosion that is just too much for our system, specifically our immune system and our autonomic system to handle.
Yeah, no, I agree.
Agreed, agreed completely. Yep.
Yeah. But tell us
And
about
then
the
of course you have to add in MCAS,
right. Well,
in
right. That's
terms of
part
that
of the immune,
explosion,
right. Well, that's part of the immune system. Yeah.
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 That's where it
And I
starts.
think and I think to even add to that, I think that we live, and not to go too off on a tangent, but we live in this very toxic world,
Oh, yeah.
with microplastics and all this, crazy stuff in our environment. And so the load, like I think of it as a toxic
100%.
load.
The exposure burden, that's what I refer to it as. Yeah.
Yeah, I think that's perfect.
Crazy. I just had a patient yesterday ask me, what about EMF? Do I think that's contributing to his symptoms? And I'm like, yeah. But my point
I mean,
is, what do you
probably.
do about
What do you
it?
do?
Right? What do you
No,
do about it? I mean,
no.
I pull up the list of networks on my Wi-Fi and I see my everyone's in my community, so
Oh,
we're all exposed.
Right.
So it's just I don't know the
yeah,
answers to most exposures. And in
I
fact,
don't either.
there was a lot of recent research showing that if you live near a golf course or in like I want to say 5 mile radius, I could be wrong on that number, but of a dry cleaner, you're at greater risk of developing
I
Parkinson's.
know.
And so it just goes to prove that exposures are really just doing us all in.
Right.
And so I agree with you. This cumulative exposure burden is really the bigger problem overall. But whatever we can control, we should control. And that's why I think there's so much focus on infection, largely because it probably is the more common exposure that at least can be easily identified in human studies,
Hmm.
with regards to just obviously blood work and urine work and so on. But also, there's something we can potentially, maybe, I don't know,
Hmm.
potentially do
Hmm.
about it, treat it.
Target.
Recognize we have all these antimicrobials at our disposal. So, if we can find the right ones to use in the right combination, maybe we really can get these infections under control, or some of these alternative therapies like the SOT, which I
But
really want to
it
learn about.
needs to
And
be
David keeps
Yeah.
interrupting me.
what?
You
I
keep
interrupted you. I'm sorry.
no, you
No, no,
didn't.
no, no. Finish what
Every
you were
time I
saying. I
ask
want to talk
about
about that second.
SOT, you
Oh,
say,
I didn't. Okay.
No, no, no.
go
Go
ahead.
ahead. Go ahead.
Sorry.
Say
Sorry,
what you're gonna
David.
say.
Go ahead.
Go ahead.
No, I was going to agree with what Eileen's saying and add that it needs to be a multi-pronged approach, not just to try to control the infection, but to, in whatever way, whatever tools we have, improve immune function and immune competence,
Right.
and also treat MCAS at the same time because it's like a triumvirate problem, a tripod problem of infection, immune competence, and the mast cell kicking things around. And what we don't have great tools for is that most important piece, which is improving immune competence.
Right.
Um,
Exactly.
but I
Yeah.
don't, I've sort of come to the point where I don't see how I can treat a tick-borne infection effectively unless I can also do something about their immune competence. I
So
think
how
it's
do you
really
do
And
key.
I
that?
say that, and I say that all the time to patients.
I
Where I
pray.
where I used to, yeah. But I used to, when I first got into that world, the minute I would see Lyme or Bartonella or whatever, right, I'd be like, oh my God, we gotta kill. We gotta just go in there and kill, right? And I've learned that, yeah, unfortunately, it really doesn't work that way,
Right.
because you could use antibiotics to kill, but unless the immune system is going to kick in to take over to keep these infections suppressed and dormant, because again, you can't kill all of them, then it doesn't work. Then the patients just continue to
Exactly.
relapse. And
That's
when I started
exactly
seeing
right.
all the relapsing, and I was like, I don't understand what I'm doing. Well, clearly the immune system is impaired. And so I look at MCAS as one way to help the immune system. I
Mhm.
do think that when you can calm down in the right patient, right, if you can calm down the mast cells and get less reactivity, I think it helps. I don't think it's the whole story, but I think it is one piece that again we have the tools at least now more and more to treat it.
Right. Yeah, and I think with all the receptors, the different medications that are useful to try to stabilize those mast cells, give us a lot of options in that regard. And sometimes it's actually hard to find which options work well for an individual patient. But, it's that kind of investigative work that I find the most enjoyable, right? To help with the patients, right? To sort of be with them on that journey where if this doesn't work, we'll try this, and to let
Right.
them know that there's a plan in place. And I think that they just really appreciate that kind of assistance that they really never expected from their doctors. Certainly I don't expect that from my doctors. So most patients are sort of shocked, I think, when we are clearly in it for the right reasons and really show that we want to help them. And I think that that's what's important because obviously these things are so complex, but there are so
Right.
many different options that we can use these days. And, you always hope that one will be the answer for them.
You asked Eileen what can be done for the immune competence. Part of the reason that I sort of took a deep dive into the whole longevity medicine world or longevity world
Right.
was precisely because as we get older, our immune system declines, not related to infection necessarily. And that then leads to chronic inflammation and the diseases of aging. And my sort of argument or conclusion in this dive was that's what we're seeing in our patients. And so I think many of the tools in the longevity sphere are applicable to our patients. So that's how I kind of got into the whole rapamycin thing. And, it just continues to grow. I mean, I see roles for improving immune competence with drugs like or interventions like rapamycin and acarbose and canagliflozin and metformin. And I think all of those drugs are things that we need to consider using in our patients, although most other doctors outside of people like us would think we're crazy.
Yeah.
And I think they really can help and really be effective. And we just don't have the research, so it's all trial and error.
And let's add in the GLP-1,
Oh
Yeah.
yeah, of
because I think
course.
Right.
that also is,
Absolutely. And then the peptide, thymosin alpha 1, I think is another
yeah,
way to boost immune function. The problem, of course, is accessing all these different things,
yeah.
without the
Right.
insurance coverage.
Right. And without evidence-based, sometimes their patients' other doctors will question why they're on
Oh
it.
yeah. Who was
Yeah.
that crazy doctor
Yeah.
giving you rapamycin?
Oh, yeah. Yeah.
All right, so tell us about SOT.
Okay. Okay, finally we got here.
Sorry.
No, no. Teasing. Okay, so
I don't
SOT,
want to hear about it. Forget it. Okay.
Psych.
okay, let's move on. Um, SOT stands for supportive oligonucleotide technique. The other term that's been used, I think is where it kind of started, is antisense therapy, which really came out of the cancer world. And I think the research was really about being able to target the cancer cell molecularly. And so they would create a protein in the cancer world. They would create a protein that could bind to the DNA, that abnormal DNA of the cancer cell, and shut it down and get it to stop replicating, right? So I think it's kind of a genius thing. And I know there are a number of universities around the country who are studying that for cancer. There's a lab, unfortunately, they're not in the United States, they're in Greece, but they started out as a actually, oncology lab, basically studying cancer. And then I think they realized that this technology could apply to infectious diseases, sort of with the same principle. If you have Borrelia burgdorferi, Lyme disease, and they can create a small oligonucleotide, which is sort of like, I mean, some people have heard the term like RNA. It's sort of like a little piece of protein that matches a piece of the DNA of that infection, of that bug. And it's infused, and it over time, over 4 to 6 months, it's targeting DNA of the Lyme bug and basically shutting down the replication, and then eventually they're dying. So they're creating lots of proteins, not just one. I mean, it's a whole bunch, probably like a million of these RNA molecules that get infused and that slowly sort of decrease the load. I look at SOT therapy as a way of decreasing the load of infection. I don't think there's any cure to these infections. Okay. I know that may be a very strong statement, but I think, David, you probably agree with
I
me.
totally agree with you.
There's no cure. And I at some point thought maybe, and Rich Horowitz wants to believe that dapsone is going to be the cure. Um, Maybe I'm all for him studying it, and I think it has shown promise. I certainly have used that protocol in some patients, but I'm not sure it's curative the way that we think of that. So the same with SOT. I don't think it's a cure, but I think it's a way to lower the load, to take the strain off the immune system. And if you're targeting the immune system at the same time you're doing these therapies, I think that you have a good chance of getting control over the situation and maybe, pushing everything into dormancy where it doesn't matter anymore, right? So hopefully now they're dormant and they don't reactivate, right? That's kind of like the state we need to get this in. So SOT therapy can be done against various viruses and various bacteria right now, and some parasites like Babesia. There are a number of strains that can be targeted from the in Babesia, a number of strains of Bartonella, a number of strains of Borrelia, lots of strains of Borrelia, Epstein-Barr, CMV, HSV, HSH, HHV6. So there are a number of different targets. You have to prove that the patient has infection from various different laboratory data. And then the lab will look for that infection and try to target that patient-specific infection. If they can't find the infection, so this has happened on occasion where we have an antibody positive, not a molecular test. We don't have a FISH or a PCR. But the patient's convinced they wanted. We had one patient who just came in because he wanted SOT, and he only had antibodies positive. I said, well, he really feels like he wants to give it a shot. I wasn't convinced with his symptoms, but let's just look. And they couldn't find the infection. So he clearly it was an abnormal antibody response. Maybe he had those infections in the past and now they're dormant. Maybe he never did, and his immune system is so dysfunctional that it's producing mimicking antibodies. Nonetheless, if they can't find it, they can't make anything up for that
Tanya,
infection.
just to be clear or not clear, I have a question about it.
Yeah.
When you send a sample of blood to the lab, um, and they have to prove or find infection, do
Mhm.
they then make the RNA or antisense molecule from that patient's blood, or do they
Yes.
have a standard, you know,
No, it's made specifically based on their that
Oh, I didn't
the
understand that.
DNA.
I thought that
okay,
there was a
and
standard like
No,
formula for the
so
SO.
it's personalized in a sense.
personalized.
Oh,
But are
wow.
they then diagnosing based on a PCR, or are they doing a molecular fish like Bob does? Or how do they, what is it that they're doing that's different than
Yeah.
what you and I do?
So that's what I will admit is a little bit confusing because what they're doing is a PCR type test. I say type because I think it's, they have some additional layers of things they're doing in addition that I think is increasing their ability to pick it up. Um, um, but how should I put this? So it's different than T-Lab. Um, it may be similar to Galaxy, maybe in terms of that technology. Um, and they also have the ability, so if you have a lab test that's positive and you're sending it to the lab, they'll look for it. They do have their own test that you can order as well. And sometimes we can't figure out what the infection is, right? And they have these various antibodies, but we're not sure. When we send them the test, sometimes they will pick up. Like I had one patient, I'll give you an example. One patient who we couldn't find she had antibodies to Lyme. We couldn't find the bugs. We ran the test. I forgot the name of it, but we ran their test and they found Borrelia mayoni, which is a strain in the Borrelia family. We'll call it a cousin to Lyme, named after the Mayo Clinic, because I think it was initially found in the Midwest, and so they were able to identify via PCR that her Borrelia antibodies were probably cross-reacting, and she in fact had this particular strain. And then they were able to create
Hmm.
the SOT based on that. So but they don't always pick up everything. That's the problem, right? So there are times when they can't find the bug, we'll say, but it's rare. They do seem to be pretty good
And so is
at
the
finding
idea
what
that
you
these
need.
oligonucleotides will then disable these bugs to continue to be present, so it'll reduce the load?
Yeah,
So it's
it's working
yeah,
for a
so
period of time. I'm
right.
sorry, go ahead.
So I was going to just liken it to what I remember about HIV, and obviously David's more the expert, which is that if you reduce the viral load, and that was one of the tests that would be run on those with HIV, that
Hmm.
what the viral load was, then it was thought to be a good thing when the load was lower, and in fact to the point where sometimes I think it was even called remission from HIV, or I don't know if anyone referred to it as curative, but to reduce the load, to reduce the burden
Hmm.
would improve the symptoms or the risks of having HIV, right? So
Yep,
it's a similar kind of notion.
similar, similar.
Well, but there's an important distinction there, which
Yeah,
is in
yeah,
HIV, when the viral load is suppressed, the minute you stop the drugs, it shoots right back up.
I see.
right.
So theoretically, that's not the case here with the tick-borne infections.
Okay.
Um,
But
well,
maybe it.
it
Well,
might be.
maybe
No,
it
it
might
might be,
be.
but I'm just talking.
Yeah, yeah, yeah.
Perhaps I mean in terms of the rate of change. I
Right.
mean, literally in
Maybe.
1 week off antiretrovirals, that viral load will go become detectable again, whereas it may
But the
take
same
longer
is
with
true.
SOT.
But it may, right. It may take longer with SOT, but it may not. I mean, certainly with
Right.
antimicrobials. I saw a patient yesterday who had, would say like within a week or two after stopping antibiotics, maybe faster, his symptoms come back, right? So he cannot get off antibiotics.
Right.
The SOT is a little different, but because it's working for a prolonged period of time. But I do have patients who they hit that four. So I said it works for like 4 to 6 months, but they're getting close to that 4 or 5 month period, and they start to see some of their symptoms coming back. Right, that's the challenge. What we find is that most patients, this is the downside of SOT. The majority of patients need multiple rounds of it, and they need multiple rounds of for the individual strain, and they need multiple rounds for the various strains that they have. Right, I've never seen in the last 10 well, I shouldn't say never, but I've almost never seen Lyme alone. Like, I don't know the last time I saw Borrelia without anything else. These patients are it's poly microbial infections, right? So, so some patients, because it's costly, they might say, okay, I know my Bartonella is really bad. Can we just do SOT for Bartonella? And they do one SOT for Bartonella, and then either they don't feel much or they notice a little improvement, and then they don't. And I say, well, because if you have all these other infections and you're just killing one, you're just reducing the load of one thing. I don't know in the grand scheme of things if your immune system is able to handle it. So in a perfect world, they're doing, let's say they have Borrelia, so they do Borrelia, and maybe 6 months later we test again and we do another round. If they have Babesia, we're staggering it. We're giving them maybe different strains of Babesia. The best example is this patient that I have who I presented on at a number of conferences. She's going into her senior year in college in California, and she has probably done. I have to look at the latest number, but let's say 12, maybe SOTs, maybe
Oh,
14,
wow.
14, 15 even over the last maybe 3 or 4 years. And what we do is we give her a round, we retest, we see what pops up, we do another round, and we just keep chasing it. Now, what we have found with her, she's like the best example, and her family's on board, and the rest of her family has also done a lot of SOTs. What we found with her is that where she started with a lot of neuropsychiatric symptoms, tremendous PANS, PANDAS stuff, with physical symptoms, a lot of menstrual problems, PCOS, glucose intolerance, just mast cell. I mean, you name it, right? She had like this whole thing. And we would, give her antibiotics and knock down a little bit. And then, when we were like in circles, right? We start doing SOT, and the analogy I'll use is like an onion. We would just start to peel the layers. right? And the symptoms would start to like one set of symptoms would disappear. Then we would have this other set of symptoms we had to deal with. Then we did the SOTs, and then we peeled the layer away to the point that really she is so incredibly like doing so well. Periods are regular now. Uh, she was hemorrhaging, anemic. It was like it was horrible. Right now, she says my periods are normal. I don't even think about it anymore. She was having trouble controlling her weight because of inflammation and insulin resistance, and that's gotten better. Her neuropsych symptoms are better. She's off of SSRIs and other things and benzos because she was on a lot of those. I mean, it's pretty remarkable how like the shift happens. But here's a case where financially the family could afford to do the treatments that are needed, and she tolerates them so well. She might have some die off for a few days. There were a few SOTs that were a little rough that we had to get her through and detox her, but like the other side of it is pretty cool and amazing for her. But that's what I've learned the more I do of these. I've probably done 500 or more at this point. Um, the more you do, the more you realize it's an amazing tool and I love it, but it has to be done pretty consistently. You have to be on top of it.
Well,
That's the
Tanya, in that
downside.
patient, the one you just described,
Yeah.
did you go to SOT after she'd had a long course of different antibiotics?
Yeah, it was like one of these things where I've been treating her since she's now, I don't know, 22 or something like that. I've probably been treating her for 10 years or so. Started treating her, she was 12. She presented with Hashimoto's. We found the Lyme. We started treating back then. I didn't know about SOT. I didn't know about any other options, right? So we would treat with antibiotics for a long period of time. She would get better, she would relapse. And then she was sort of off everything for a while, was doing really, really well, and then it exploded. The neuropsych symptoms just literally out of nowhere, right? And so, what tools do I have when she's away at school and I can't like see her right away? Okay, we just throw antibiotics. But, at that point, that was maybe 4 or 5 years ago when I really started doing a lot of this. I started like in 2018. I was dabbling in it, and COVID hit, right? But then certainly by 2022, we were like really in the doing the most of it. So it's really the last few years that I have this amazing tool. And that's when we really, right. So she'd been treated for a long time. And finally we said, now the antibiotics were causing SIBO, causing fungal overgrowth, and all this other stuff that we were having to undo. And she said, no more antibiotics. We got to find another way to do it. And so that's where we got to the SOT.
So do you see the advantage of SOT that it's as effective? It's as effective as antibiotics, but with less side effects. Is that the
Yeah.
kind of what you
That's
see?
what I'm seeing.
And then the flip
Yeah.
side of that is that it only treats one organism at a time, whereas antibiotics
Right.
can treat all of them at once.
Well, if you look at antibiotics, right, there's no one antibiotic that treats
No,
all
not
of them,
one.
right?
I don't mean one
Oh,
drug.
but you mean like an antibiotic protocol when I have her
Yeah,
on
yeah.
four different
Let's
things, and
say,
yeah, yeah,
Doxy and Azith and Mepron. You're going to treat.
oh, yeah,
Okay.
Babesia and Lyme, maybe, yeah, yeah,
All right.
You did mention
And
the patient had some die-off for a couple of days. Is the die-off
yeah,
similar to the antibiotics that they have, the
yeah,
Herx reaction? Is that
yeah.
it's the same.
It can be the same.
It's not any better with
No,
OT.
no, and for some patients they don't have anything. Some patients have like day 3 to 7, which is kind of also I see a lot with antibiotics. They might have a spike. For some of those patients, it's a little more prolonged, especially if their MCAS is not well controlled. They definitely have more symptoms for longer. And then sometimes what you'll find is that because the way the SOT is working, again, over a period of time, they may have another Herx, a month or two later. All of a sudden, they're going through another round of killing,
Hmm.
essentially, and then they have more die off. But the one thing that I think is important, David, like that we think about when you say antibiotics, most antibiotics are bacteriostatic, right? Not
right,
bactericidal,
right. That's part of the problem.
which is the problem, right? Because it's only suppressing.
Yeah.
Whereas I think SOT has the benefit of being bactericidal, I think,
So let me ask you two
theoretically.
questions, Tanya. One, do you ever give antibiotics at the same time since you're only you're using a sniper rifle with SOT and
Mm.
a shotgun with antibiotics.
Right,
Is there
right.
value in doing both at the same time? Theoretically, if you have
Theoretically, yeah.
organisms not being treated, they're going to continue to impair immune function. Would there be a benefit in knocking, a wider attack, so to speak?
So that's the challenge, and you bring up a very good point because you can give SOTs just to sort of think about the logistics of it. I can order several at a time based on patient's testing.
Oh,
I can only give one at a time, but I can give them 2 to 3 weeks apart, let's say. 3 weeks is, they say, is optimal. But if I have patients from out of town, we will do it a little shorter. Some patients are really sensitive. We'll wait a little longer. But the goal is to try to get them in so they're not waiting too long and the other bugs are not taking a hold of them, right? So that's one, strategy. The issue that we run into is that the lab that's making the SOTs has done their own research, and they feel that if you try to do a lot of antimicrobials at the same time you're trying to infuse the SOT, you may decrease the effectiveness because the target that the SOT is looking for may not be as visible, right? So if you've lowered the load a little bit with antibiotics of whatever, like if you're doing again the shotgun approach and you have them on something that may be killing a few different things, and then you go in with one SOT, maybe that SOT won't be able to find the target.
Right.
So that's the biggest challenge. Having said that, there are patients that we really have a hard time getting them off antibiotics because they relapse so quickly. So we have to, it's almost like a little dance. I might say, look, they relapse so quickly that I know that if I just take them off antibiotics for a few days, the lab says 14 days. There's no way I can get some of these patients off for 14 days, right? So I might do a few days and I know they're going to relapse anyway, right? So I feel like their target is going to be obvious. Go in with the SOT, wait a little bit, as long as I can to get that SOT to where it needs to be working. And then if I have to go in, but maybe if I'm doing, let's say an SOT for Lyme, maybe I can go in with like a Zithro Mepron for their Babesia, which is not going to cover the Lyme as much. So maybe the SOT can continue to work, right? So it's a little bit, yeah,
Yeah.
truly the art
Yeah. No,
art
that
of
makes
medicine
sense. That
there,
makes sense. That's
yeah.
the whole issue with bacteriostatic antibiotics, actually, and how you have to be careful what you combine with. My other question is on the SOT. You say it works for 4 to 6 months. How come the body doesn't, you know, respond to this foreign
Mm,
product?
yeah.
How is it able to circulate for 4 to 6 months and not be removed?
I don't know if it's circulating or whether it's actually in the it becomes intracellular.
Mhm.
Um, that's the question. That's an excellent question because you'd be you'd wonder, right? Because it is a short protein. Why wouldn't the body start to fight it?
Right.
That's kind of what you're. Yeah,
Yeah,
it's a
exactly.
great question. My guess is that it's intracellular, maybe, and in a way at the level of the DNA, it's binding at that, intranuclear. So I don't know, maybe that's fighting it from the rest of the immune system. But it's a good
Hmm.
question. Yeah, something to think about.
Hmm. Well, it's oligonucleotides, right?
Hmm.
Yeah. So, I mean, I think it would be taken up inside the cell.
Yeah, so it's not really circulating in the bloodstream. Is It's taken up by the cell, and then in the cellular level, I think it's as the cells are multiplying, they're passing along that oligonucleotide and hopefully killing, right? I think it's a process, but
Well, I mean, it sounds like an incredible
complex.
treatment, though. I mean, David, so you've never used SOT, David?
I've referred to Tanya for that. No, I just never learned how to do it.
Yeah. Look, I think it's a tool. My whole thing is that we just need more tools because these patients are so complex.
Mhm.
The standard way of treating just doesn't, maybe 10
Yeah,
years ago we thought it
I
worked, it
agree.
doesn't, right? So I love having these. things that, I think everyone, again, is going to react differently. And some people, it's going to be, life-changing, and some people, it's not going to be enough. Can't guarantee with anything we do, right?
Right.
But it's been a really exciting tool to have because it's definitely minimized the amount of antimicrobials that I use. It really
So
has like
would you,
dramatically decreased.
when you have a patient, a new patient or a patient
Mhm.
newly diagnosed, do you usually start with antibiotics and then go to SOT, or are you starting with SOT?
I'm almost always starting with SOT.
I
Wow.
understand that though, because obviously I don't do this the same kind of work that you do, but and I've said this to Dave before, like I used to just do a lot of trial and error with a lot of the medications that we all talk about. But I've gotten a lot more aggressive in the past 6 months because I just feel like, these patients have been so sick for so long. Like I don't want to waste a lot of time, like, oh, let's just try some, of the beta blocker class, or let's try, I go right
Yeah.
to, I think, more like heavier guns kind of thing, trying to really, again, just sort of control the mast cell, to control the inflammation, support the immune system. And I've become a lot more just daring, I guess, in the way of just trying to get patients better faster. And and it's just because we see such
Yeah.
complex and such sick patients. And so I really feel like that's what they want from us.
Yeah.
Right.
Yeah,
So
Yeah,
I
I agree. I
agree.
I
mean, that's
totally
something you and
understand that
I've,
sentiment. Yeah.
yeah, we've talked about that definitely. I agree with you.
Yeah.
Yeah. I've
And-
changed also. I also was sort of like, oh, okay, we have MCAS, so let's start with the H1 blockers and the
Yeah.
H2 blocker, and I still do that, right? But these patients, this has been a long road for a lot of them.
Exactly.
So
And they've
you
already tried
really do
anti.
have to do,
By
right?
the time
Many of
they're
them have.
seeing us, they've already tried all the antihistamines.
Yeah.
I no
Yeah.
longer even bring them up because it's like, yeah, I mean, what am I going to tell them to go to the drugstore and buy some Allegra? I mean, they've already tried it, or they're already on it. They're already on
Yeah.
the antihistamines, So I really feel like they come to us for, an elevation of recommendations, like not the
Yep.
standard, clear what the obvious ones are kind of thing. So, so yeah, and I take that seriously. And so that's why I'm always just sort of reading and talking and having conversations with doctors like yourselves, trying to sort of learn more and understand more of how you approach things and what tools you have in your arsenal, so that I have better things to offer as well.
So in terms of mast cell, I agree with you completely. Why don't we, I keep wanting to, but I never quite have the guts. Why don't we jump right to imatinib and hydroxyurea?
I have been recently.
Yeah,
Very,
good.
Really?
yeah.
Okay.
And
I'd
what are
love
you
to hear
seeing?
yeah, I'd love to hear what your experience is.
Yeah, well, literally in the last couple of weeks, I've just started with Gleevec and a bunch of patients who are like bedbound and just chronic, everything just, they have such an intense neuroinflammatory response that everything just sort of is like gas to a fire. And I just sort of had started to see it as they have this barrier that doesn't allow the medications that I am prescribing to have its effector function because it can't get through that barrier. And so we need to just sort of get rid of these mast cells just to sort of clear the way so that these medications even have a chance of helping. And so I'll let you know about how they're doing because this
Yeah,
was literally in the past 2 weeks that two patients that I've had that are so chronically ill, their stories are so heartbreaking, that I just felt like we just need to just hands down, we need to get this
yeah.
done. So
I was doing it for a while, going very quickly to imatinib, but then I was disappointed in the responses.
yeah,
I thought it would be the game changer. What am I screwing around for? Let's just go straight to imatinib. But
right,
it does not work uniformly that well. I don't know if
right.
Tanya, if
I
you've,
agree with you, David.
it's
Yeah.
very,
Well,
I don't have
Larry will
one.
print his great cases of,
I
I
he'll
know,
know.
which
write
is
them
what
up,
made
but
me, right, which is what motivated, it's his cases that he talks about that was what motivated me to just like, let's just
right.
try
But
this.
it hasn't been
Know
my
that your
experience.
experience hadn't been
Yeah.
the same. Yeah. So
No, I don't have one positive imatinib case. Not one,
Wow.
which is so disappointing.
I don't know.
Um, no, I'm sorry, but maybe you will have it, right? And Larry certainly. I will tell you where I jump a little faster these days, though. I will jump a little faster to the GLP-1s.
Oh, I do. Yeah, I
Yeah,
agree with that. I
yeah.
agree with that. I go
I'm
right
ready to do a
there.
GLP-1 on the first visit at this point.
Yeah, me too. Me too. I very,
I mean, look,
I also, I jump to anatomy. I will say that that's been one of my things.
Jump to what?
anatomy,
Yeah.
anatomy. I think that oftentimes when I have these refractory severe cases, I think that there is something going on in the anatomy. And I fully admit that I sometimes overread imaging, but I scrutinize them though, looking for reasons why these patients are so sick. And when you do that, you find things that you don't see in other imagings, right? And then it's like, okay, here's the anatomical problem. The issue is that what are you going to do about it, right? So am I going to send everyone for surgery? And clearly that's not my goal or my motivation, and certainly my patients don't want surgeries. So even if I find something that I think is the anatomical cause of the issue, I don't always have great answers for it. And so and sometimes I actually find just evidence of like chronic inflammation, and it emboldens me to say we really have to do what we can to reduce this inflammatory response, because this is what I see on your cord, on your brain, and
Mm.
this is scary. And so, but sometimes if I see a malalignment that I think is causing compression where compression shouldn't be, then I think, okay, if we have to avoid surgery, then what are the options? I mean, obviously there are the injections, there are manual therapies, there's still reduction of inflammation to sort of help improve the ability to realign things. So anyway, and I know this is sort of a little bit off topic of tick-borne illness, or maybe a lot off topic. Although I think
No,
Well,
tick-borne,
no,
it's
maybe
not.
that's what's
Not
causing
at
it. It's
all.
not
right,
off topic at all.
No, I think it's really relevant, and I love
Yeah.
your take
right.
on this.
So I just jumped to that a lot faster than I used to, frankly.
Yeah. Yeah. I agree.
So,
I mean, GLP-1 in the first visit,
Yeah.
almost. And the other thing is the screening for May-Thurner syndrome.
yeah,
I
me
have
too.
bought in totally to that whole thing that's again on Masterminds recently. Over and
Yeah,
over and
pelvic
over, I
congestion.
find it. So I'm not waiting until their POTS is refractory. I'm just doing it early on.
Should we be stenting like everyone
Yeah.
with POTS then if they have?
I
Should
Sure.
we?
would.
You would? Do you see POTS improve with stenting?
Yeah, I do. Not everybody, not as much as I'd like to see it, but it definitely seems to help.
Yeah.
The
Okay.
problem
I
is
don't know.
it's the same problem. Let me
Okay.
in answer to your question, the problem it's like when we treat tick-borne infection, that may get something better, but their MCAS and their SIBO and their leaky
True.
gut and their POTS is still cooking. And if they get stented, they still have the other problems cooking. And it is a little bit like whack-a-mole, or plugging the dike with all the holes. And that's very frustrating for patients and certainly for us, for me. Um, but yeah, I do think if you have a patient with POTS and they have clear-cut um, venous compression, Matherner type compression, yeah, that needs to be fixed.
Hmm.
I mean, just thinking of it again as plumbing, if you can't get enough blood to return to the heart, you're never going to get enough output and um,
So the
stroke volume.
problem, the problem I have, I'm gonna play devil's advocate because I'm all in with this, and I've talked to Alexis Cutchins about this. I did a she was on my podcast. We talked about this. She spoke at ILADS last year about this. She's doing an ILADS webinar with Brooke Spencer, who's the IR person in
Right.
Colorado for ILADS. So like I'm all in, but the problem I have is, have we looked at normal people and whether they have venous compression? Because I'm going to give you a little story. Um, Alexis was looking at, actually, I had her look at, a number of different scans that I have of various patients, right? And so I was trying to figure out, should I get them screened or whatever? And so, like every single patient I showed her had compression. Um, Now, though these patients have symptoms, I understand that, but now I'm thinking, what if I get, people who have been scanned for another reason? Now I have to figure out, why would they be scanned for another reason? What other symptoms would they have? What is the real prevalence of, venous congestion, or let's say iliac vein compression in the general population? Like, are there people walking around with it
Okay.
that are fine? That's what I want to know. How
So,
you want to do randomized controlled studies on all. I want to know how many people who are normal have this too.
all right. So Alexis actually put a post on today.
Oh,
Ready?
perfect.
Okay.
Okay.
I'm reading from it. The
Okay.
presence of left iliac vein compression in the general population parentheses, all comers, which means the number includes our patients, it is not a
Okay.
finding only in normals, is 40 to 60%. So
That's a
that's a
big,
lot of
that's
people.
that's a lot of people.
But as she says, it includes people who actually have a problem. It's not a normal versus
Mm,
our
okay.
population.
But what
Okay.
problem? Like what, right?
Well,
So
when I
all
think she means
comers.
POTS. So it's all comers. I don't know where she got the statistic from because she doesn't give the reference. Um,
All right, we'll ask her for that.
yeah, and I think
Yeah.
that's an important. But your point, Tanya, is very well taken. How many people walking around with Maytherna and they have no problem? My answer is also how many people are walking around with Bartonella and they have no problem, right?
Yep.
I
Yep.
mean, I've
Yep.
stopped
Touche.
doing antibody testing for that reason because every time I ran Galaxy antibodies, they were positive in every single
Yeah.
patient. The only
Yeah.
patients that weren't positive were the ones where they had active PCRs. Go figure,
Right.
right?
Right. Right. No, that's a good.
I
It's a
mean,
good. It's an
infection is
excellent
different
point.
than a compression, right?
No, I know, I know,
Yeah.
I know.
Right. So asymptomatic from a infection versus a compression is, I think, is a different ball game. So
And actually, Eileen, I would love to ask you, in how many people who are normal would you see misalignment, some other anatomical
often,
issues, right?
yeah, often,
Right? Yeah.
Yeah,
right.
Yeah.
For sure. There's no question. I mean,
yeah,
it's funny. It's like when you are always looking for something, you always see it, right? So when I'm getting imaging for patients who are not the classic chronic complex patient, but are referred to me for other reasons, and I order imaging, I still see things like cranial cervical instability. The morphometrics are usually, borderline. They're not profoundly abnormal, but they're borderline. And I'll say you have mild cranial cervical instability. And the more questions you ask, the more they may have some mild symptoms of it, but sometimes they don't. So you
yeah.
see it all the time.
It's the reason that this is obvious to us, of course,
Yeah.
that the history is so absolutely critical because
Yeah.
it's so
Yeah.
easy to fall into the trap of overreading the data, overreading the labs, overreading the imaging. Um,
Mhm.
and if it doesn't fit with the clinical history of the patient, you can really make some serious mistakes. And again, I like the analogy of the overflowing glass of water. So you can have CCI and the glass isn't overflowing and the patient's fine. Nothing's happening. They're able to cope. Their body manages it. You can have Maytherner and nothing happens, but then something else happens or some additional insults occur and suddenly that glass is overflowing.
Mhm.
And it's true in infection and it's true in anatomy. It's going to be true in, you know, neurologic brain disease. You can have lots of little strokes in your brain and there's no clinical evidence of that. And then you get one more and bam, that glass is overflowed.
Right.
So it's a very murky
Right.
area.
But these kinds of issues are why randomized controlled trials can be important, right? Because it can really
Yeah,
help us discern what's abnormal and what's not, or more
That's
important,
right.
when we should intervene and when we shouldn't.
right,
Because you certainly don't want to put a patient under an intervention that doesn't really have a good chance of having a positive outcome. And, so I think because, and as you know, patients come to us to help guide them in the
right,
decision-making process. And I find that very challenging because I don't have enough data to support making a recommendation of intervention or no intervention. All I know is this patient is suffering. And if there's even a small chance the intervention can help them, of
Mm,
course, I want to support them in making that decision, but I don't know enough yet to sort of know that to be true. So I find that to be the most challenging part right now at this point in the time of our, journey in chronic and
right.
complex illness. That's the most challenging thing that I have right now.
So I think I didn't speak as clearly as I should on terms of sending patients for
mm,
Maytherna studies. Okay. When I say do it right away, I think the approach I'm taking is kind of, Eileen, what you were saying, which is I want to get as much information as possible, as fast as possible in the beginning. I
Mhm.
don't want to wait because these patients have suffered already for so long. They've been to dozens of doctors, et cetera, et cetera. So I will make an early referral to Brooke Spencer's group. But that doesn't mean I'm not going to, at the same time, aggressively treat their POTS. but it does mean I'm not going to work on that for 6 months if it's not getting better. Once I find that they have Maytherna and I've already got them on a beta blocker and I've Aberdeen and fludrocortisone and they're still like fainting or whatever, then I'm going to send them much sooner. I just want to be clear about that. And I
Yeah.
think that's true for a
No,
lot of
that
what we're all
that
doing.
makes sense. Yep.
Yeah.
Yep.
Absolutely. Absolutely. I think it depends upon the symptoms also. I think, yes, POTS for any kind of autonomic dysfunction, I think you have to just sort of search out why, where it's coming from. I mean, the autonomic nervous system is triggered by peripheral input, right? So if there is any kind of compression and therefore blood flow is compromised on any level, sometimes that affects the way the peripheral signals sort of are integrated into the autonomic nervous system. So it is important to sort of look for reasons for the symptoms specifically. Um, yeah, and so yeah, I agree.
So would you say that, Eileen, from a, let's say, an anatomical perspective, you can, by looking at these different like you're obviously doing a lot, with the spine, right? And right, so things that are related to the nervous system. And then, Dave is talking about the pelvic veins, and I'm sure you're looking at that too. So I guess the question is, how much of these patients' problems are anatomical for their dysautonomia? What do you think? Like, this is obviously we don't know. This has never been studied, but like, what do you think in your experience? How much of the dysautonomia can be addressed anatomically?
I think a lot of it.
Yeah, that's what I was going to guess that you would say, but
Yeah.
yeah.
I really do. I mean, even pain is an autonomic response, right? I think a lot of these patients sit in sort of this sympathetic, hyperactive state. And so, which I think ultimately results in a lot of their symptoms, including the pain, the fatigue, headaches, vertigo, muscle pain. I just think that there's just too much tension within the sympathetic part of the autonomic nervous system. And then I think, and also don't forget the autonomic nervous system controls a lot of what our body does, including, of course, a lot of our gut function, but even, vasomotor regulation, right? So how it constricts or dilates, appropriately or not for change of volume and pressure, which is a change of position, our heart rate, our respiratory rate, our blood pressure, temperature regulation. I mean, a lot of our patients will say that they're always cold or they're always hot, or a hot
Right.
shower actually will provoke symptoms. This is all an autonomic function. So something is causing that autonomic disarray. And I really firmly believe it's infection. I used to question that, to be completely
Mm,
transparent, but since the COVID days, like I said earlier in the podcast, like I just see autonomic catastrophe on all these long COVID patients. And now I see in the ME/CFS patients. And so I now
right.
am fairly convinced it's actually related to an infection. And again, whether it was the COVID that itself or that it reactivated, as you guys were talking about, the reactivation of what was dormant and latent and just sort of sitting around in our cells and our bodies. It's something having to do with the infectious provocation of the immune system, which then, there is an immune autonomic. So there is a neuroimmune axis that I often talk about, and
Mhm.
part of the neuro part is the autonomic nervous system, and then there's the immune part. So I do think that there's this integration that
Mhm.
has just gone chaotic.
Yeah. The
And
post-infectious autonomic storm.
Yeah. Yeah,
Yeah.
exactly.
right. And do you think that that's what's impacting the anatomical findings
Yes.
that you're
Yes,
finding then? Is
I
it sort of
do.
like that snowball? Yeah, I agree. I mean, that's how I look at it too.
Yeah.
But
Well, the body's notoriously intolerant of unstable joints in general. So, I think that again, the mast cells release a lot of those enzymes that break down, that love collagen and break it down. And a lot of the immune cells and with the inflammatory response have those kinds of mediators that love to just break down collagen and other components of the connective tissue. And so you don't have to be an EDS patient. You don't have
right.
a history of hypermobility necessarily, right? So you have this
Right.
chronic inflammatory response that starts to break down the connective tissue, and then you get pieces of your anatomy that
Yeah.
are no longer in alignment.
I mean,
And
you
so
and
I,
Eileen,
Mhm.
you and I have talked often about how uh, it almost feels sometimes with our patients who don't have EDS, theoretically, that we can just watch their connective tissue
Just,
failing in front of us because of their
Absolutely.
infections or their chronic inflammatory
And I know
illness.
that to be true. And one of my, I have like a million ideas for papers, which I never have time to write.
Mhm.
But one of the, I have at least five patients that I've been seeing for a bunch of years. I mean, obviously, but that I've done imaging on early on and then recently. And I could see the change. I could see it on
Yeah,
radiology.
Yeah.
So I could prove that this, and I know their history in between, right? Because they've been my patient. So I want to write a paper to sort of say, like, this is what happens when we don't get chronic inflammatory responses under control. This is where the
exactly.
anatomy starts to
it
fail.
needs to be, it needs to be published. Bob Mosiani published a number of years ago on a patient who presented with EDS. It was almost like a new
That is the
onset
greatest
EDS.
paper. I've referred to it so many
And
times. Go ahead.
always, right? Because it's
Yeah.
amazing,
Yep.
right? New onset EDS that reverses when the
Mhm.
Bartonella infection is
I've seen
treated.
it. Oh, I've
Right.
seen it. Yeah.
Me too.
I read
Me
that
too.
paper. It's an amazing paper, but it's what I see in my practice when I get
Yeah.
patients well again.
So,
Yeah.
Tanya, let me
So
bring
that,
this back to,
oh,
I'm sorry, go ahead.
I just want to make one comment since we're
Yeah.
talking about connective tissue. So, doxycycline, right, inhibits MMP9,
Hmm. I know. I use
right?
it for
Which,
that.
right. So I have a few patients, I have more than a few patients, who do well on doxycycline, right? And they think they're doing well on doxycycline because it's killing their Lyme, right? It's bacteriostatic. It's not bactericidal. I don't think it's really killing the Lyme. It's probably resistant because some of these patients have been on it for on and off for a long time. But that doxy is doing something for their connective tissue,
Right. Right.
which is, and it's incredibly anti-inflammatory and a mast cell stabilizer. So I think that sometimes we just also have to think about the interventions, the antibiotic interventions we're using, because they have multiple functions. And so
Right.
I think doxy is a really interesting tool for people with connective
Yeah.
tissue issues. I just had to
I
put it out
completely
there.
agree. And I regularly use it when the MMP9 is too high and there's evidence of mast cell activation. I will also point out that sometimes, some level of MMP9, even if it's slightly elevated, is important because it can represent remodeling of the
Sure.
connective tissue, which might be
Yeah.
regenerative in its nature. And it's really hard to discern that in any individual patient.
Right.
But certainly, if there's clear mast cell activation, clear inflammatory response, the MMP9 is high. I put them on doxy and I see it come down. So, and I see their symptoms improve, frankly. So I do, there's a
Yeah.
lot of different tools that over the years that I've sort of learned to do. And I definitely see people's anatomy improve without surgery, but just by aggressively treating,
Yeah.
usually with a combination of plasmapheresis, IVIG,
Yeah.
all the different meds that we use that just to get their inflammation under control. And then we start to see them improve. And then their anatomy, you repeat imaging and there's an improvement in their anatomy. I've even seen compressions improve.
I
Uh,
believe that.
yeah.
I believe that.
So,
Pretty cool.
So
Sorry,
I was
David,
going
you
to
were going to
say,
say
no,
something.
no, this is actually a perfect segue to my question, which is going back to tick-borne infection and the treatment. So if we agree that it's a reactivation infection and we agree that it can't be cured, why don't we consider treating it the way we treat those patients who frequently have HSV1 or HSV2 reactivation or EBV reactivation
Mhm.
or I can't really say tuberculosis, but meaning why aren't we using chronic suppressive therapy? So if I have a patient with tick-borne infection, why don't I treat them with doxy and azith for the rest of their life? And I
So
don't know the answer to that. I mean,
I don't know either. And I have patients, a couple who I can't get off
me
antibiotics,
too, me too.
mm,
and but they do well. I know we've talked about some of those cases, right? So they, they do okay. Their gut is okay. Their labs look okay. Their liver looks okay. Yeah. I don't know what else to
Yeah,
do,
I mean,
and
we
they're
put
doing
people on
well.
Valtrex for their whole life. We
Yeah.
put people on
Yeah.
antiretrovirals, very toxic drugs for their whole life, and we saved their life. Why aren't we, why aren't we doing that?
Yeah.
I mean,
Because I think it's complicated, and of course, we have that sort of school of thought on, the dangers of
yeah, I know. I know.
antibiotics, dangers,
yeah.
and I'm not saying that it's unfounded. I mean, there are some downsides for sure, But I do think that, I think there are some patients who I think it's okay. Like if I have to keep them on doxy for a prolonged period of time and their gut is okay and they can tolerate it and they feel better, the connective tissue feels better. Those patients that they complain that like anything they do, there's something like some joint hurts, there's some ligament hurts, something they're not able to be active and they go on doxy and they're able to be more active and they feel better. And and they want to stay on it long term, right? I don't know. I have a hard time arguing against it. So I'm with you, but I just don't know if it's appropriate for everybody. When we make decisions like that, if does a young person stay on antibiotics for 50 years? Or, I don't know, but you
Right.
raise a great
Yeah, I'm not
question.
saying I know. I mean, to
Yeah.
me, it's
Yeah.
a big,
So it's a
important
good
question, you know?
philosophical question. I know. I know.
Yeah. No, these are the
I know.
struggles for sure. When to stop a medication, when it's been helpful, but maybe it's been too long, you know.
But should we, right? And so unless like I feel like unless you can prove that that drug is really dangerous, doing something bad to the body. Patients are the ones that often, right? Sometimes they will say, I want to stay on it, but very often the conversations I have with patients when they come in is, when can I go off of this
Yeah,
stuff? When
Right.
can I
because
stop? Right,
they're also getting internet chatter about it and they're getting
Right.
feedback from other physicians and other people. I mean,
right.
it's funny, everybody will be very negative about the antibiotics, but they'll have no problem taking Valtrex for their whole life
Mhm.
or like I said, the
Exactly.
antiretrovirals. And,
Right.
Exactly.
you know, antibiotics sort of have developed a very bad rap, and
Yeah.
it's not a good thing. And including mainstream medicine. I mean, I'm sure,
Mhm.
Tanya, you and I get criticized because we have patients on antibiotics for 3 months, let alone 2 years, you know?
Yeah.
I know.
So,
Well, there's not only the antibiotic resistance argument, but also the chronic infection argument. It's still, I mean, it's still controversial, right? I
Mm.
mean,
yeah, very controversial. I
right.
mean, mainstream doesn't believe it. I mean, I'm sure, look, I'm sure this is true for both of you. I have patients that get, quote, infectious disease consults,
Mhm.
and they
Hmm.
say, what are you talking about? That's a fake lab. T labs is bullshit. It's ridiculous. And you're
Oh
on
yeah.
antibiotics from that crazy doctor? You're nuts. Don't you know what's going to happen?
Right.
They just don't accept what we're saying. And yet there's pretty overwhelming evidence about the chronicity of these infections, the reactivated nature of these infections, and the whole shift from, replicating to stationary phase.
Correct. Persistence, right,
Yeah,
in that stationary
yeah.
phase. So lots of evidence, right? But
I have to
but
attend
people want to
some of the
believe.
ILAD things.
What?
You what?
I have to go to some of the ILAD.
Come in. I'm going. You should come.
When
Come
it,
come to
It's October, right?
yeah, October 7th through
In fact,
10th
the
or something
deadline is
like that.
August 1st. I got to do my registration.
For the meet, well, I have to do it too, and I have like 4 talks, but I
Yeah,
haven't
I know.
registered yet.
oh, you're giving talks, Tanya? You're giving talks?
Yeah,
Oh, wow.
I'm doing a GLP-1 talk.
Oh, fantastic. Oh, I really want to hear that one. Where?
Um, it's in San Antonio.
Oh, Texas.
Fly direct flights,
Yeah.
Eileen. Believe
Direct
it or
flight to
not,
San
Seattle to San
Antonio?
Antonio. This is a direct flight.
Really? Ooh, I might come. I might be
It
there.
would be great to have you.
I would love,
Um,
it'd be my first.
yeah,
And you should go, Eileen, actually. You really should.
I have so much to learn.
Well,
there's and this year I'm on the program committee, so I'm really proud of the schedule, the agenda that we've put together. We've really tried to cover what I think what you'll appreciate. There's certainly lots of talks on the specific bugs themselves, but there's a lot of talk about the terrain
yeah. Yeah,
Oh, I
that's
love
what I liked in the
right.
schedule when I looked at it. That's what convinced me, Tanya.
because it's the terrain where the bugs live,
Yeah.
Yeah,
right? And so there's a
that's what
little
I'm
bit of a
most
shift in
interested
our
in.
focus. Me
Yeah.
too.
Yeah,
Me
I've no,
too. Like, what
I
else
have
can we
very
do?
little interest in becoming like an infectious disease doctor. Like an
Nor should
microbiology
you.
was,
Yeah.
I still have PTSD from microbiology in med school, but I really am interested in how it affects the terrain, and I love that term. But, so yeah,
Yeah.
that's what I'm really interested in learning more about.
I still
Yeah.
remember my microbiology professor. That's so funny.
I can memorize all those organisms. Remember that?
I loved
I
it then.
blocked I blocked it. I literally blocked it out. I have no memory of that. Isn't that funny? I just don't.
Like the rods and the cones and the cocci and the.
Well,
But look
that'll be
how
good if you
useful
come,
it's turned.
Eileen.
Yeah,
No, it'll be great.
this was a really, really great conversation. And I think David, it was like almost 2 hours, and I think we
I
wanted
know.
to try to, but we'll just figure it out. And the truth is that listeners and watchers, like you guys can just do it in pieces or, because I know that's a
Exactly.
long one.
There's a lot of
It was
stuff we
a
can
great one.
recover
It
for
was a
sure.
great one. We covered it a lot. And so, yeah. And yeah. So I'm
And
so
I think we need to do it
excited.
again because I can think of many other topics I'd
I,
love
I have a million
to
other
dive
questions that I
into,
knew that I knew if I were to ask like one of the questions that were sitting in my head, it would be like another
Would you
hour
like to know?
conversation.
Right.
So
Yeah,
we
we've
will
been at
wait
it two
until
hours.
Dr. Tanya Dempsey can come to Seattle and we can sit in the studio and just
100%. I
keep
can't
it
wait.
fit.
We'll do it. We'll do it. We'll do
I
it.
can't
It's
wait for you to
awesome.
be here. It'll be fun. We'll take you to lunch. We'll make it a day.
Yeah, that'd be
I've
great.
never been
Really,
to Seattle, so I have to go.
It's
I
great.
have to. I've never been.
oh my
Isn't that
God,
crazy?
you have to come and
I
try to
will.
East
I
see it
Coast people
before the
don't
winter
even know
comes.
Seattle
We don't
exists.
even know what it is. Right.
Yeah. Oh no, you have to come to Seattle. Yeah. And now is a great time of year up until about October. So let us know when you think you can come. We'll arrange for a studio time and we will just do this again and cover more.
Absolutely.
But this was a really, really good
Yeah.
conversation.
So this was great.
Thank you.
I hope
Love it.
people watch it and watch it in
Yeah.
pieces, Eileen, as Eileen suggested. Um, and we have our usual rambling back and forth, but we had a great time. So thank
Yeah.
you for watching, everybody.
I had an
Yeah.
amazing time.
And
Thank you.
thanks
Okay.
again, Tanya,
Thank
for
you,
being
Tanya.
here. Honestly. We'll see
My
you soon.
pleasure. My pleasure. Love you,
Okay.
Ben.
Bye.
Bye.
Bye.